Attendees are in listen-only mode.
Good afternoon, and thank you for joining us for the Crisis Stabilization and Withdrawal Management webinar. I'm Heather Bradley at Adirondack Health Institute. And first, I just wanted to go over the different project goals. So for Crisis Stabilization, the goal is to provide readily accessible behavioral health crisis services that allow access to appropriate levels of service and providers, supporting rapid de-escalation of the crisis. And for withdrawal management, we're developing withdrawal management services for substance use disorders, specifically ambulatory detox, within community-based addiction treatment programs that provide and link to care management services. On your screen, you'll see that there's a link to the milestones and metrics. They have not changed since the end of last year when we looked at them. They're what we're going to be basing our high-level work plans off of to make sure that everybody's meeting the requirements. As we're looking at the different implementations for the different regions, for crisis stabilization, Fulton, Northern Adirondack, Plattsburgh, and Queensbury identified as doing implementations for crisis. And for the ambulatory detox, Northern Adirondack and the Plattsburgh region submitted applications to do those implementations. We wanted to update you that there's an updated budget template, which is available right now on the DSRIP blog. The modifications to that template are very minor, and they're noted in red on the template. Should you still have budgeting questions if you weren't able to attend the presentation in Lake Placid, our CFO, Lynn Wadley, will be doing a webinar on Friday, March 6th from noon to 1. The registration link for that webinar is also on the DSRIP blog. And we want to note that those budgets are due back to AHI on March 13th, submitting to the DSRIP email address with the subject line of project budget. Other things that are going to be due on March 13th would be the speed and scale templates, which will be posted along with this presentation, the PowerPoints, and the recording on our blog tomorrow. For the speed and scale template, you're going to also submit it to the DSRIP email address using speed and scale as your subject line. And we're going to go through those templates right now. So there's different counting methodology for the two different projects. For ambulatory detox, the counting methodology is number 3. Basically, at the beginning of each DSRIP year, you will start recounting patients. So you cannot duplicate a patient, but you can count them in multiple years. For crisis, however, the counting methodology is different. It's methodology number 2. And you can have one person be counted multiple times in 1 year. It's based on the number of crisis services they receive. Now, again, that one's not additive, so those numbers both reset to 0 at the beginning of each DSRIP year. Looking at the speed and scale template for crisis stabilization, at the top you'll see noted that there's 4 crisis intervention programs. So we're looking for the organizations that will be involved in those crisis programs, and we marked as a network-wide PPS that DSRIP year 3, quarter 4 is when those crisis intervention programs would meet the requirements, all requirements for the project. What we're looking for you to do is list your organization and then which year and quarter you think your program will meet all of the requirements for the project. You can certainly do it sooner than that year, but no project can be completed later than DSRIP year 3, quarter 4 based on the commitments we've already made to the state. At the bottom, you'll see noted the information about actively engaged patients. With regard to crisis, an actively engaged patient is someone who's participating in receiving crisis stabilization services. So when we look at those numbers in red, they're listed as 2,211 for DSRIP year 2, quarter 2, and it jumps up to 5,529 in quarter 4 of DSRIP year 2. And like we said, it's not additive, so it resets to 0 for year 3, and that's why you'll see a lower number DSRIP year 3, quarter 2 than you did at the end of year 2. Again, list your agency and give your best guess of, based on capacity, how many patients you think will be receiving crisis services. And we previously had to list them out based on every 6 months. Now we're asking you to list them out based on each quarter. So we're looking to have those blanks filled in. Withdrawal management, the template is a little bit different. If we look at the bottom first, your actively engaged patients, it's the number of patients who receive outpatient withdrawal management services at participating sites. So we're looking to have you list your organization and again those patient numbers at the bottom. The top on this template is far more confusing. You'll see noted primary care physicians, clinics, etc. Those numbers in red are the numbers we used to send to the state based on information they had sent to us. What we're looking for you to do is not to list out all of those numbers that we have there. However, we would like you to list your organization and the year and quarter you believe that you'll meet all of the project requirements for the withdrawal management project. So if you list your organization name in that yellow box and then you can just place an X in the year and quarter, that will complete the upper portion of this template for withdrawal management for us. On this slide, you'll see that the DSRIP years align with calendar years, the exception being DSRIP year 1 starts April 1st of this year, so it's a short 9-month year. Moving on to work plans, the metrics and milestones we mentioned earlier are what these high-level work plans will be based off of. You can choose to do a work plan as one large regional group and submit that to AHI, or you can choose to do them in your individual regions and then submit those regional plans to us. And if you have questions or want to have a discussion about which way you think might work best for your groups, we can do that during the Q&A session. Work plans will be due back to AHI on April 22nd, and they will again be posted to our blog for this project. When we're talking about work plans, each project will have a project champion, so we're looking to identify someone in our region who would like to champion these two projects. This champion may, depending on their skills in their region, want to champion both crisis and withdrawal management, or they may seek to just do one, in which case we would have two champions for the two projects. We're looking at someone dedicating approximately 1 day per week with a value of about $20,000 annually for this person who would be a project champion. And that champion is really going to be overseeing and monitoring progress in the different regions. They're going to be the subject matter expert, and they'll participate in statewide learning collaboratives. They'll be setting the agendas and facilitating meetings with the regional groups on this project. They will be supported by the AHI project manager for these two projects. Myself, Heather Bradley, will be the project manager, overseeing them and working with the project champion or champions to effectively bring these projects through completion. As project manager, I will be working on meeting planning and communications with all of the team members, working to do reports and other materials you might need, and tracking progress through the DSRIP tracking tool. So we look at the timeline. March 9th, AHI had an opportunity to be able to add any missing providers to our network or people who wanted to maybe join but missed that November submission deadline. So on March 9th, AHI will submit any additional providers to the state. And then on March 13th is the big date for these regional teams. We're looking to get those budget templates and the speed and scale templates back so that we can then in turn get our draft of our implementation plan to KPMG, our DSRIP support team, by March 16th, who will then send us feedback and help us send everything in we need for April 1st, which is the final implementation plan due date to the state. We wanted to mention to you the MIX, which is the Medicaid Redesign Team's Innovation Exchange, and Jason Helgerson at Medicaid has been very excited about talking about the MIX. Right now it's mainly being used to have different PPSs communicate with each other. However, there's going to be the functionality for PPSs such as AHI to have closed groups. So we're encouraging everybody to go log in and create an account on the MIX, as it looks like something the PPS will be using in the near future to deal with additional communications. At this point, I would like to open it up to questions that you might have. You can ask a question by typing in your question section or by raising your hand and we can unmute you. Okay. It looks like at this point there's no questions. So I'm going to conclude the webinar with a reminder that all documentation from the webinar and templates that you'll need will be posted on the AHI blog tomorrow. And should you have any questions, you can certainly feel free to email me. Thank you all. Have a great day.